I know you're probably as surprised as I am, but it's time for another Puscast. This one covering the first 2 weeks of December 2010. This is the last podcast of this year, so I'd like to wish all my listeners a generic, non-denominational seasonal greeting. Remember, you can always skip this introduction. This is brought to you by Pusware LLC, publisher of the Infectious Disease Compendium, a Persiflager's Guide, an iPhone, iPad, something or other app. Because this is CME accredited, I have to mention potential conflicts of interest, just the vast sums I generate from my website. Otherwise, I ain't got none. The opinions, of course, are all those of Mark Crislip, MD, and Pusware LLC, and nobody else who knows the difference between a burro and a burrow. As always, join my growing multimedia empire. 3 podcasts, 2 blogs, and a partridge in a pear tree. All available over at moremark.squarespace.com. And as always, go on iTunes and write me glowing reviews. Or call me a closed-minded, arrogant tool of the medical industrial complex. I don't care either way, but just give me 5 stars. And now, the literature. The following is an example of why infectious diseases is so much fun. Now, you're probably unaware, but there is a Gambian pouched rat. It's found in Gambia. It is an animal with poor eyesight, so it has a very good sense of smell. In Africa, it's routinely eaten as bushmeat. It goes under the name there of beef. Gambian pouched rat. It was also responsible for the importation of monkeypox in that outbreak in the United States a couple of years ago. But because of its sense of smell, it has been used to detect landmines and, in a recent study, tuberculosis. They trained the animals to smell out TB, and they found that the rat had a specificity of 89% for the samples looking for tuberculosis. In the study, they used smears to determine the presence of tuberculosis or not in 10,000 patients and found that smear found 13% of TB, but they picked up an additional 620 cases that were later confirmed by having the rats smell the sputum. Now, TB always occurs in areas of low resources, so this would be a pretty good screening test for tuberculosis in a resource-poor area. And the upside is that when the rat reaches the end of its natural life, dinner. There are 2 HIV viruses. There's HIV-1 and the cleverly entitled HIV-2. What can you say about HIV-2? Well, it's less transmissible. It progresses slower. Many patients do not progress. They have lower viral loads, and it evolves slower. But the patients do and can eventually get immunodeficiency syndromes as a consequence of HIV-2. This study out of Clinical Infectious Diseases asked when should you look for HIV-2 specifically in patients. Basically, as people who are from or travel to West Africa, where HIV-2 is endemic. And also suspected in patients who have odd Western blot banding on their HIV tests. And they give the example of some patients who presented for all the world as having HIV disease, but had negative viral loads and negative Western blot for HIV-1, when in fact what they had was HIV-2. So, if you have a patient from West Africa, and it occurs to me that I do right now, think about HIV-2. When it comes to medicine, I'm an Occam's kind of guy. Although I use Gillette's razor in the morning once I go to work, I like to use Occam's razor in determining what patients have as a cause of their diseases. Sometimes, however, you have to use Hickham's dictum, which is the patient can have as many diseases as they damn well please. This study looked at 10,000 plus clinical specimens for the detection of respiratory pathogens in patients who had H1N1. So they had 10,624 samples with H1N1. And they found that a third, 29.3%, yes, I know that's not exactly a third, had other pathogens. And the most common ones were the classic ones associated with post-influenza bacterial pneumonia. Staph aureus, 15%, strep pneumoniae, 10%, Haemophilus influenza, 3%. And then a smattering of other bacterial pathogens, as well as a smattering of parainfluenza, rhinovirus, and Coxsackie virus. The dealio here, though, is that influenza damages the lungs and makes it fertile soil for bacterial superinfections. So patients who get influenza, not unsurprisingly, get secondary bacterial pneumonias, and having that kind of colonization/infection rates is pretty impressive. So the threshold for starting antibacterials in someone with influenza should be set fairly low. I am, of course, and not unsurprisingly, what would be considered pro-vaccine. Vaccines, flush toilets, and good nutrition are the reason that we get to live to a crotchety old age and get off my lawn, punk. Anyway, the New England Journal of Medicine published an article on the effectiveness and safety of the H1N1 vaccine in Beijing. They had mass vaccinations over 4 days of 95,000 kids and looked at the results of that. They found of the people who were vaccinated, there was a rate of influenza of 35.9 per 100,000 students versus 281 per 100,000 in similar unvaccinated students, putting the vaccine effectiveness at 87.3%, which is pretty good considering that match between the vaccine and the flu was excellent. So you can predict under best case scenario maybe almost 90% efficacy of the influenza vaccine. They also looked at complication rates. And during this time, they had 27 cases of Guillain-Barré. None, this is important, none of which occurred in vaccine recipients. So it would appear that the H1N1 vaccine that was used in these children was both very efficacious and safe. Now, children in schools are an interesting source of influenza. There was an editorial in Clinical Infectious Diseases this month about how schools are the epicenter for flu spread, that the close contact of children and lack of immunity leads to rapid transmission of flu in the community, and then it tends to get out into non-students. So the sort of potential vector, if you want to ablate it, would be to get kids vaccinated. And there were old studies in the 60s to show that if you highly vaccinated school children, that there was less influenza in the community than those who didn't highly vaccinate school children. As always, the efficacy and benefits of flu vaccine are far more complicated than get the flu vaccine, don't get the flu. If you want to see my particular take on the recent Cochrane meta-analysis of flu vaccine in healthy adults, head on over to Science-Based Medicine for Friday the 17th. Hepatitis E is one of those emerging causes of hepatitis that we probably miss on diagnosis. There's several kinds of hepatitis E, depending on what part of the world you travel to. This study looked at all the hepatitis E's in Italy, and they found that there were two types. There was travel-related hepatitis E, which was primarily due to genotype 1, and picked up while traveling to places where that particular strain is endemic. And then there were those who had no travel history and picked it up from pigs and boars, eating undercooked or other swine. Swine. These patients tended to have genotype 3. So there's two types of hepatitis E. The type you get traveling, type 1. The type you get from eating pigs, type 3. The good news is that this was a self-limited disease in all patients, and by 4 weeks, everybody's ALT had returned to normal. Type 1, the one found in third world countries associated with high mortality in pregnant women, appears to be more virulent than type 3, the one found in pigs. It may explain why people in the United States, while often being hepatitis E positive, that we don't see the mortality rates in pregnant women that they see in other parts of the world. By the way, 1 in 5 red deer in Spain are positive for hepatitis E. So, don't be consuming no red deer while traveling in Spain. I wonder if Santa knows that Rudolph the red deer has hepatitis. Probably not. If you've been a listener of this Puscast, you know by now that I have a real affinity for weather-related infectious diseases. I got 2 this month. The first used historical satellite maps to determine rainfall in Tanzania, in Africa, and then looked to see what the correlation with human bubonic plague was. And they found that heavy rainfall, as judged by photographs from satellites, had a significant correlation, 82%, with subsequent plague incidents, and that incidents occurred about 2 months later. So it's probably happening. Lots of rain equals lots of plants, equals lots of food, equals more rats, equals more plague. I mean, the one nice thing about drought is there are not a lot of infectious disease associated with it. Unfortunately, you get to starve to death instead. Good sides, bad sides. Can you tell the difference between the entry you just heard and the entry you're about to hear? I just saw Harry Potter and the Deathly Hallows Part 1. Enjoyed it quite a bit. The true axis of evil is North Korea, Iran, and the Foley catheter. And so far in the last 10 years, more people have died from the Foley catheter than the other two combined. Although that should change should either the other two lob a nuke at us, as they may very well do. The issue now with urinary tract infections acquired in the hospital is A, you have to report them, and B, Medicare isn't going to pay for them. They're supposed to be a never happen. Right. But one of the questions is always, can you prevent catheter-related urinary tract infections? And one of the ways that is done is to give a dose of antibiotics with pulling of the Foley. This randomized placebo-controlled trial compared a dose of Bactrim, a dose of ciprofloxacin, or a dose of placebo just before urinary catheter removal and looked at both significant bacteriuria and urinary tract infections as an endpoint. And not unsurprisingly, single dose of antibiotics did diddly. The infection rates were respectively 3%, 0%, and 3%. And were not statistically significant. Unfortunately, the only reliable way to prevent hospital-acquired urinary tract infections is not to instrument the patient, which sounds like you're putting a flute in the bladder. You know, there are always issues as to when and who should get radiologic tests, and recently there's been emphasis on the fact that CAT scans are a potential risk for the long-term development of cancers. It's more important in kids and pregnant women than it is in some 80-year-old person who's going to die of a stroke soon anyway. But still, you hate to give people needless radiation. Well, it depends on the person. This study looked at who should get urologic imaging for a febrile urinary tract infection. And they came up with a simple rule that if patients had a history of stones, that's kidney stones, not the Rolling Stones. You don't want Mick Jagger to be getting a CT every time he shows up with a febrile UTI, now do you? But if they had a history of stones, a urine pH greater than 7, or a GFR less than 40, they had a reasonable probability of having a positive finding from imaging. They found that the negative predictive value was 93% and the positive predictive value was 24%, which is not bad, evidently. These kind of studies always make my head hurt. But as they say, quote, total score of 0 to 3 points was computed for each patient. Of 336 patients, 57% had 0 points, 37% had 1 point, and 6% had 2 or greater points. And their likelihood of having a relevant radiologic finding was 7% if 1, 15% if 2, and 79% if 3. So those seem to be relatively good predictors that you will find obstruction or abscess in the kidney in someone who hits the ER with a febrile urinary tract infection. It sometimes seems that the indication for CT is presence of pulse and respiration. I know that exaggerates a wee bit, and I tend to get CTs fairly easily in my patients, but I have a biased practice. Still, it's nice to know and have guidelines to help determine when you need to do urologic radiographs in patients with febrile UTIs. It's the implementation of these studies that's always difficult. Sometimes I think one of the unwritten rules of the treatment of infections is that once antibiotics are started, nobody can stop them, except, of course, me. This was a retrospective study that looked at de-escalation of empiric antibiotics in a med-surg unit. They looked retrospectively at what happened to patients if their antibiotics were simplified based on cultures, or they continued the same old for infinity or until the patient died, whichever comes first. And they found that there was no adverse effects to de-escalation. They found they did decrease the number of antibiotics used, but that also that there was a decrease in recurrent infections and no change in mortality. So once the blood cultures come back, switch to monotherapy with whatever the simplest antibiotic is to which the organism is susceptible. Multiple antibiotics do not prevent infections. In fact, in some studies, they cause E. coli to become resistant more rapidly than monotherapy. And of course, anytime you wipe out an ecological niche with antibiotics, it will soon be filled with bacteria that are resistant to whatever antibiotics you have them on. Some guy named Darwin, I think, first discovered this principle. Anyway, de-escalation is safe. You can, in fact, you should decrease and alter your antibiotics based upon culture results. What a concept. I do sometimes think that antibiotics are used more like magic spells. He harkens back to his Harry Potter movie today, than they are like actual scientific chemicals being used by rational people. But then, I've been called an arrogant subspecialist who doesn't understand the pressures of primary care. And now we move to the hodgepodge. Not the John Hodgson, but the hodgepodge part of our Puscast. First, and these are usually negative studies I've noticed. I noticed that negative studies don't need explanation because you can just say, don't do it. I don't know if you could not do this, but this study looked at the rates of HIV transmission due to circumcision in gay men and found, at least in Peru, it did not alter the transmission of HIV. I figure anything that you acquire through repetitive action will eventually fail. Guess what else is associated with developing HIV disease? Using drugs and getting drunk, or associated with unprotected sex. Who would have thought that? Thank God the Swiss figured that out. At least they didn't find chocolate consumption and wristwatches was associated with HIV disease. But next time you get drunk and stoned, you may not use a condom. Water is wet, fire is hot. An unfortunate study out of Italy showed that dogs do not get H1N1. Bummer. Our neighbor's dog barks all the time, and I can think of nothing better than for that piece of crap dog to come down with a bad case of flu. There is a couple of cases of Lemierre's, which is septic thrombophlebitis of the internal jugular, that's internal jugular, associated with infectious mononucleosis. Maybe it is, maybe it isn't, but interesting. Did you know that koi have a herpes virus? They do indeed. The common carp, which is an important food for consumption as well as Japanese gardens, gets its very own herpes virus that causes its gills to rot away. There's actually been a major cause of death in carp. I know you don't care, but I just find it interesting. I think I discussed earlier in the month a herpes virus in, I believe, clams or oysters or something like that. Or if I didn't discuss it, it was reported. It seems like everything can get herpes. There's a case where brucella reactivated in the gallbladder 28 years after the initial infection. That would not be a record for Staph aureus, where I've seen 60 and 70 years from initial infection to reactivation, but still that's out of 2 standard deviations for the average brucella infection. 10% of patients who get treated for Whipple's get an immune reconstitution inflammatory syndrome. We're kids, we're middle-aged, we get old and turn into children again. I think Shakespeare said it better than I did, certainly. But it also tends to follow the arc of meningococcal carriage. They looked at it over age and found that for childhood, meningococcal rates are about 4 to 5%. It peaks in the 19-year-old, which is also in meningococcus has been peaking as a disease of late, when 23% of 19-year-olds can carry meningococcus. And then by the time you're 50 and decrepit and in a wheelchair and using Depends, it's back down to 7 to 8%. So your chance of carrying meningococcus varies with age. Now, rifaximin is used all the time to treat infectious diarrheas. It is related to rifampin and is not supposed to be absorbed, and why would you think that it causes resistance? They took 11 volunteers and gave them rifaximin, and before you know it, voila, they had rifampin-resistant skin staphylococci. Quote, a total of 11 rifampin-resistant and 3 rifampin-intermediate staphylococcal isolates were found. Bummer. The motto in infectious diseases has always been use it or lose it, but I'm impressed with how quickly you can get rifampin resistance by using rifaximin. There's a systematic review of using chlorhexidine versus povidone iodine for preoperative skin antisepsis. Yet another study that shows the superiority of using chlorhexidine. When they pool all the studies, they find you get fewer wounds if you use chlorhexidine. Anybody still using iodine as your surgical pre-op? Come on, join the modern era. For severe Acinetobacter infections and Pseudomonas infections, adding intravenous plus aerosolized colistin did nothing over intravenous colistin alone. So, bummer there. These are organisms that are very hard to kill at baseline. I love these sort of statistics, but 1 in 6 Americans get foodborne illnesses every year. 128,000 are hospitalized, 3,000 die from eating tainted food. And what do they get? Well, they get the usual hodgepodge. Norovirus, Salmonella, Clostridium perfringens was a whopping 10% in this study, which quite surprised me, followed by Campylobacter, and leading and finishing up with Listeria, which was a mere 19% of diarrheas. Still, the same old bugs are in our food, and we eat them every year, year in and year out. It's why I only eat fried food. As I said before, the advent of fried beer has removed the final obstacle that I needed to have a safe diet. And a case report of somebody who got a tattoo and then developed Mycobacterium abscessus in the tattoo. There have been other percutaneous injuries associated with Mycobacterium abscessus. I need a tattoo for my midlife crisis. I'm trying to debate between a barcode on my forehead and a tramp stamp that says, "Do not enter." You can vote online for what my tattoo should be. Not really. Malaria in Africa is associated with urban vegetable gardening, and people that are in and around urban vegetable gardens are exposed to malaria year-round, as opposed to those who aren't, probably due to increase in standing water and mosquito populations. Bummer. And that ends our hodgepodge. So, we come to the last Puscast of 2010. I should do a year in review, but I give grand rounds every year that's a year in review. And I'll try and record that and toss it up for those of you who don't want to listen to this every 2 weeks. Now for the usual crap I have to say at the end. That's the end of this Puscast. Review the ID literature with commentary. References are available on the website. Since it's CME accredited, you can listen to this, then take the online quiz and get a half an hour of free CME. Thank you, Legacy Health. Brought to you by Pusware LLC, the publisher of the Infectious Disease Compendium, a persiflager's guide, your Uber hyperlinked electronic guide to infectious diseases, an iTunes app, and available online. Don't forget to join the growing Mark Crislip multimedia empire at moremark.squarespace.com, where you will find my 3 podcasts, 2 blogs, and a partridge in a pear tree. Bandwidth ain't free, so feel free to purchase the compendium even if you don't have an iPhone and support this Puscast. It's copyright 2010 under the Creative Commons license. The music is by my son when he was 12, improvising on the guitar. Feel free to email me. I'm not much for responding to emails. I should be better. But then I need many improvements. I need to be thinner, taller, have more hair. But instead, I ignore email. And as always, thank you for this most interesting consultation, allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you. In dictation. Goodbye.